Hi, everyone. We want to start in next 5 minutes, if you agree. Thanks for joining us to the third session of the Rheumatology CPC series held by Rheumatology Research Center of Tehran University of Medical Sciences, Shariati Hospital, in collaboration with International Affairs Deputy of Tehran University of Medical Sciences. Before starting the case, let me introduce our team and our speakers who accompany us in this session. I'm Faiza Bijani, Assistant Professor of Medicine at Tehran University of Medical Sciences and Head Manager of Educational Developmental Office of Shariati Hospital. This session is directed by Dr. Tahira Faizi, Professor of Rheumatology, Head of Rheumatology Division in Shariati Hospital, and Head of Connective Tissue Disease Unit in Rheumatology Research Center. Dr. Faizi.
Hi, everybody, and thanks for joining us, and thanks all of the invited speakers to accept our invitation, and we hope to have a great discussion about this challenging case and have a great meeting with us.
Thank you, and let me introduce Dr. Elahe Baharvand, Assistant Professor of Medicine at Tehran University, Shariati Hospital. Elahe, thank you for having you.
Hello, everybody. Thank you very much. I'm really glad to be here again, and I hope we have a real good session today. I just wanted to ask everyone to rename their devices to their full name so that we can have a better communication, and also for the certification of attendance, we would need your names to be exactly the same as the one that has been submitted in the website. Thank you very much.
Thanks, and we're so much honored to have Dr. Khosrow Shahi for the second time in our sessions. Dr. Khosrow Shahi.
Thank you for inviting me. I look forward to have a great discussion, and I'm honored to be here with great speakers and you guys.
Thank you so much. And let me introduce Dr. Afrouzian. We have Dr. Afrouzian also for the second session. She is Associate Professor of Pathology at University of Texas Medical Branch, Galveston. Dr. Afrouzian, thanks for accepting our invitation for the second time. Your voice is muted, Dr. Afrouzian.
Sorry, I was saying I'm honored to be here, and I hope that we'll have a wonderful session like the previous one.
Thank you so much. And let me introduce Dr. Manila Gyad, Associate Professor of Hematology at the Department of Hematology and Medical Oncology at Winship Cancer Institute of Emory University. Dr. Gyad, thanks for having you with us and for accepting our invitation.
Thank you so much. I'm so excited to be here. I look forward to the discussion and learning from everyone here.
Thank you so much. And let me welcome to Dr. Kirill Lyapichev, Assistant Professor of Pathology and Director of Hematopathology and Flow Cytometry Laboratory at USA. Dr. Lyapichev, let me welcome you, and we're so much honored to have you here.
Thank you very much. I'm very happy to be here, and I am looking forward to discuss this interesting case and learn from everyone. And I hope it will work out, and a lot of people will enjoy our discussion and learn from our talk. Thank you.
Thank you so much. We have Dr. Eleni Ansulatis, but we don't have her video. Dr. Ansulatis, if you hear me, please turn on your video. We're so much honored to have you here. Dr. Eleni Asolatis is Assistant Professor at Department of Neurology and General Internal Medicine at Emory University. Thanks for having you with us.
Thank you so much for having me. I really look forward to the discussion and to meeting you all virtually.
Thank you so much, and let me start a case. We want to discuss a case, a 16-year-old girl who was presented to the emergency department with chief complaint of confusion, anemia, and thrombocytopenia. The patient had malaise, frontal headaches, lightheadedness when rising, fatigue, palpitations, shortness of breath, and episodes of nausea and vomiting occurred that prompted her to leave school about 7 days before admission. And also 2 days before admission, she saw her primary care physician. The examination was reportedly normal and no abnormality in laboratory tests were found, and no laboratory tests also were requested. And the symptoms were attributed to the recent tapering of prednisone and stress associated with the school. She has a diagnosis of lupus nephritis that had been made for her 3 years earlier with hypertension and proteinuria for about 1.8 grams of protein per day, developed after the initiation of oral contraceptives for dysmenorrhea and did not resolve after discontinuation of the medication. At that time, the erythrocyte sedimentation rate was 49, and a renal biopsy was performed for the patient revealing immune complex glomerulonephritis. The ANA level was positive at a titer of 1 to 1,020 with a speckled pattern, and also a positive double-stranded DNA antibody with a titer of 1 to 20. And also anti-Rho, anti-Lao, and other serology markers were also negative. Also, the serum complement levels were normal, and also renal function tests did not reveal any abnormality. Consequently, mycophenolate mofetil and prednisone were administered for the patient, and an improvement in proteinuria was occurred, and also ESR decreased to 13. At a routine follow-up about 2.5 months before admission, the ANA level was also positive with 1 to 160 titer with a speckled pattern, and also a positive titer of antibody to double-stranded DNA. The dose of prednisone was tapered gradually over a period of 6 weeks from 10 milligrams daily to 10 milligrams every other day. She also had a history of obesity, dysmenorrhea, a right ovarian simple cyst, and also tracheomalacia as a toddler. The patient had been born by cesarean section after a full-term gestation and was adopted shortly after birth. Her drug history included mycophenolate mofetil, 1 gram twice daily, prednisolone 10 milligrams every other day, and enalapril 10 milligrams twice daily, norethindrone 0.35 milligram daily, ergocalciferol 4,000 units daily, and no known allergies. She was of African-American ancestry and lived with her adoptive parents and an adopted sibling. She was a good student, did not smoke, did not drink alcohol, did not use illicit drugs, and in her biologic mother's family, they had diabetes mellitus and hypertension history. At approximately 9:30 p.m. on the night of admission, right-sided weakness and numbness involving the face, limbs, and abdomen occurred for the patient. The patient's parents took her to another hospital, arriving at 11 p.m. And on the examination of that hospital, she was awake, appeared in distress, she was frequently moaning, and she was complaining of abdominal pain. In the physical examination, the temperature was 38.4 degrees centigrade. Blood pressure was normal, and also pulse rate was 98, and respiratory rate was 18 breaths per minute, and an oxygen saturation of 100% in ambient air. Dry oral mucous membrane was detected, and strength in right arm was reportedly decreased. The gait was unsteady, and the remainder of examination was also normal. An EKG was performed for the patient, which revealed no abnormality. Creatinine, kinase, and troponin level of the patient was normal. Urine analysis of the patient showed 1+ proteinuria and otherwise normal, and a brain CT scan without contrast was performed for the patient, revealing no any abnormality. Subsequently, hydromorphone, metoclopramide, ondansetron, as a normal saline were administered for the patient intravenously, and during the next 2 hours, the patient reported that numbness extended to involve the left side of her body. Confusion increased and agitation developed. Approximately 2.5 hours after arrival, she was transferred to the emergency department of a third hospital, arriving 40 minutes later. In more precise history and physical examination, no chills, diarrhea, rash, cough, or nasal congestion or discharge revealed. The vital signs were normal, and oxygen saturation were normal. The patient's mental status alternated between somnolence and agitated. She opened her eyes in response to voice or touch. She did not make any eye contact or respond to any questions. She moaned frequently. She occasionally called for her parents, and she showed purposeful and symmetric limb movements in response to stimuli. Her speech was intermittently compressible, and other neurological examination revealed no focal abnormalities. The remainder of physical examination was normal. Dr. Faizi, let's have a discussion here.
Yeah, thank you, Dr. Vijani, for your nice presentation. And now we have a patient, a 16-year-old girl with a history of lupus nephritis since 3 years ago, that who present with some constitutional manifestations such as fever and some neurological manifestation that start a few days before this presentation and progressed during the administration in this hospital. And she saw her physician 2 days ago before the admission, and whenever the primary care physician attributed her manifestation to the tapering of the steroid dose and to the stress due to school. Now we have a lupus patient with constitutional and neurological manifestation. I have a question from the Dr. Ansolotis that when we have a lupus patient with neurological manifestation, what's your differential diagnosis for this patient, and what's your diagnostic approach for her?
Dear Eleni, your voice is muted.
Hello. Yes, so with a patient with known lupus who comes in with a variety of neurologic and neuropsychiatric manifestations, I think the first question is whether or not they are developing neuropsychiatric manifestations because of their lupus and in association with their lupus, or whether or not the symptoms are secondary to an unrelated pathology. So at 16 years old, I think you have a little bit of a benefit here because, you know, we're assuming her only diagnosis is lupus and the associated renal disease with lupus. She doesn't have other comorbidities that may predispose her to some of the like broader differential diagnosis. The way that she presented with kind of this gradual, maybe 1 week to multi-day emergence of worsening encephalopathy in addition to other deficits is concerning for neuropsychiatric lupus. Typically, the neuropsychiatric lupus falls into a couple of different categories, some of which are more acute than others. The development of focal neurologic deficits, albeit transient, really start to raise the suspicion for a intracranial vasculitis secondary to lupus, or another related etiology that is enough to create either an episodic interruption of blood flow and focal neurologic deficits, or something like a seizure, which can create focal neurologic deficits, and some seizures are unwitnessed. So I think the approach to diagnosis, and then obviously there are other unrelated etiologies, but I think the first thing to start looking at is whether or not she has neuropsychiatric lupus. The differential for her, in addition to seizure, is obviously a TIA or a stroke. It is something like an encephalitis. She is on immunosuppressive therapy, so she may be more at risk for developing, intracranial infections, such as encephalitis. So I would say infection, seizure, secondary to anything, right? A stroke, given the focal neurologic deficits, and then not having, having completely normal labs, at least so far, that we've been told. I think I would start my exploration there. In anybody, particularly in children, the diagnosis of stroke and the guidelines, at least the guidelines from the United States stroke guidelines, really recommend MRI as a first imaging modality if it's available. And for this particular child, because your differential is so broad, and because the symptoms, at least the focal symptoms, started relatively recently, I think I would start with an MRI of the brain, and ideally I would do it with and without contrast, in addition to other laboratory assessments like blood cultures and things, to start looking at stroke versus an encephalitis versus a cerebritis, which may have changes on MRI. I would also include vessel imaging of the brain with either a CTA or an MRA to look for specific patterns of of intracranial vasculitis, which would include the major intracranial vessels having like a beaded appearance, like sausages on a string, or a beaded appearance, which may signify a vasculitis rather than general neuropsychiatric manifestations. So I think I would start there, and then also engaging, our rheumatology colleagues for other manifestations of lupus, and then just a broad infectious workup and a broad laboratory workup.
Yeah, thank you, Dr. Anstolakis. You mentioned that we need MRI for this patient to exclude some involvement such as vasculitis or cerebritis or encephalitis. Could you differentiate between the cerebritis or encephalitis due to non-autoimmune disease and non-immunologic, such as a viral infection, from the neuropsychiatric lupus by MRI with contrast or not? Can you differentiate between these diseases?
No. So typically you're going to pair your MRI with a lumbar puncture in this patient. She's young, infections on your differential. You're going to pair it with a lumbar puncture. Now, and the differences between the MRI appearance of a true lupus vasculitis and other etiologies like multifocal stroke, if that's kind of what is going on with her. The fact that her symptoms started on the right side and they were focal and then they moved to the left is very peculiar in stroke, unless she has multifocal strokes. So the appearance of an MRI in the setting of lupus cerebritis versus multifocal stroke versus, other etiologies is not going to be made by MRI alone, but I do think that it's a very nice first step. If you can do this, right, you want to always try and do your MRI with contrast before you do the lumbar puncture. Now, if you are really concerned about infection in this particular patient, you may need to like pull that trigger and get the LP, the lumbar puncture immediately. But a lumbar puncture that comes before an MRI with contrast, the contrast of the MRI, because you've essentially created a small CSF leak with the lumbar puncture, can artificially enhance the meninges. And because you're looking for competing etiologies that may also be that may also have meningeal enhancement, you really want, if it's possible and if you can hold off, to get the MRI before you pursue a lumbar puncture. The MRI and the initial labs would ideally come first, and then an LP. An LP would be sent for like your usual studies. It would also be sent for, depending on the hospital system that you're working in, often MRIs will have like a PCR panel. Sometimes it's called a biofire panel or an encephalitis panel that tests for a variety of viral illnesses via PCR. You would want gram stain, typical studies. You'd want to save some additional fluid on your lumbar puncture.
Yeah, thank you, Dr. Ansulatas. You said that we need LP to exclude the manifestation due to the infection disease. Is there any finding in the CSF that show us that it may be related to neuropsychiatric lupus, such as high level of IgG or oligoclonal band, or for example, phagocytosis without low glucose level? Can you tell us more about this?
So if you have an autoimmune process in the CSF that is driving CSF changes, yes, I'm sorry, I forgot to mention that in the LP. You want to get you want to get oligoclonal bands, you want to get an IgG index, which sometimes is orderable from your lab as an IgG index, but it's not just IgG, right? If you only have an opportunity to order IgG, you also have to order serum albumin. CSF albumin and serum albumin, so that you can calculate an IgG index. But serum oligoclonal bands and an IgG index, in addition to your typical studies, will sometimes help identify whether there is like an inflammatory or kind of protein-driven pathology in the brain. The differences between a central nervous system infection and a lupus cerebritis or an intracranial vasculitis, in a perfect world and ideally, should be that in the autoimmune vasculitis or an autoimmune cerebritis, you should ideally have elevated markers of inflammation without subsequent elevations in white count, right? So you should have a high protein, you should have all of the clonal bands, which are not specific to multiple sclerosis, as some of us were trained to think, but are just a general marker of excess protein production in the CSF, and an elevated IgG index. In the absence of a gram stain finding, in the absence of elevated white blood cells, and in the absence of a viral a PCR diagnosis of an infection, would all point toward an autoimmune pathology rather than an infectious pathology, which, depending on if it's bacterial or viral or fungal, would have different characteristics, but all of which would have increased white blood cells. Now, this particular patient has been on immune suppressive therapy for a period of time and may not be able to mount that response. And so particularly for fungal etiologies, which can have high protein in the CSF and for which she may be more susceptible to because of her immunosuppression, you may get a very muddy picture in the CSF where somebody doesn't have an elevated white count, has elevated protein, and that picture may be the one that you get in a person that can't necessarily mount the white blood cell count response because of their immunosuppression.
Thank you, Doctor. What about the type of the cells in CSF? Is there any difference between the infectious disease and neuropsychiatric lupus, neutrophil dominant or lymphocyte dominant?
I think if you look at a textbook, then maybe, but you have, in your variety of infectious diseases, right? Your bacterial diseases should have a neutrophilic predominance. Your viral diseases should have a lymphocytic predominance. If she had a seizure as the only manifestation of this, she may have a pleocytosis. If she had a stroke, you should see kind of a normal picture, but then over time you would see a neutrophilic predominance potentially, a lymphocytic predominance potentially. And in lupus cerebritis or autoimmune driven either lupus cerebritis or lupus vasculitis, you're either typically going to see a pleocytosis or a lymphocytic predominance. But it's not, I should know this. I don't know the sensitivity and specificity for those findings. But in my somewhat limited exposure, we see all kinds of things in the CSF with these patients. And so I wouldn't drive your differential based on the kind of textbook representation of what should be in the CSF, especially because this woman is on prednisone, albeit lowish dose of prednisone, but prednisone.
Yeah, thank you, Dr. Ansalotis, for nice discussion. I have a question from Dr. Khosrowshahi. Dr. Khosrowshahi, nice to meet you again. What's your idea about the diagnosis of neuropsychiatric lupus for this patient with a history of lupus nephritis?
I'm sorry. Say that. I didn't hear that part. I'm sorry.
I asked from Dr. Khosrowshahi.
Yeah.
Yeah, I think Dr. Ansalotis covered very nicely the way that we approach these kind of patients. And as she mentioned, I mean, when you come to see a 16-year-old who comes with fever and kind of subacute presentation of mental status, you have to cover all the bases. And when we call neurology, usually emergency room has kind of like excluded metabolic or toxic causes if there is a drug or anything that has, changed the mental status. So we are really dealing with making sure that this is either lupus and inflammatory, lupus CNS involvement or an infectious etiology. And as she mentioned, it's really hard in these patients to differentiate, but we have to time the imaging and CSF kind of like evaluation correctly to be able to get that. And I mean, I completely agree. In lupus patients, majority of the time when we do the CSF analysis is to exclude other causes and make sure that we are not dealing with infection, because I have seen HSV and encephalomyelitis presenting very similar to this CNS lupus patients. So it's very important that we exclude those. So imaging by itself is not going to be kind of like helping us to diagnose. So we have to exclude infections. And then for CNS manifestation of lupus, it's such a spectrum and such a range in these patients that, definitely you want to make sure it's not thromboembolic from antiphospholipid. That we don't know her history of antiphospholipid antibody status. And Dr. Gadi is going to talk to us about that probably more, but those are patients that we see a lot coming with thromboembolic events. And then just encephalitis or CNS vasculitis can present like this in many of our patients. Definitely her past history of glomerulonephritis and the proteinuria was mentioned by Dr. Afrouzian, increases the risk of thromboembolic event even in the absence of antiphospholipid antibodies. So MRI is going to be important for those. I think that's the approach, getting all the lupus markers in the blood, getting the CSF to exclude infectious etiology, and at the same time, definitely lymphocytosis, elevated protein in the CSF, oligoclonal band or IgG index. Those are good suggestive markers that can help us, but the key is to exclude infection.
I will also say that in some instances, those are send out labs. So you're going to be waiting time to get them back. And so while they may help you a week in, they're not going to help you immediately. I'll also say, antiphospholipid antibody is certainly a concern. I think that's something that an MRI would help drive those laboratory workups. So if you saw a stroke in her, you would definitely be working her up for antiphospholipid antibody. And while glomerulonephritis predisposes to thromboembolic disease, it's typically venous thromboembolic disease. So unless she had a PFO and she was vomiting and she had Valsalvas and that PFO caused a paradoxical embolus because she had a DVT, then you can certainly see that, but it's usually venous more than arterial, with the exception of antiphospholipid antibody. So I think your MRI will drive some additional laboratory questions for this particular patient, but totally agreed on the kind of general approach to the workup so far. And if where you get to is either nowhere with this first set of imaging and your labs start to reveal other pathologies, obviously you're going to move in a different direction. But right now, this is like a fulminant autoimmune process, right? So your lupus cerebritis, historically, your neuropsychiatric manifestations of lupus typically come about very, very slowly. Your mood disorder, your cognitive decline, your headaches, those are the most common manifestations, neuropsychiatric manifestations of lupus, and they happen over time. This is a woman that had a rather abrupt onset of symptoms. So you're kind of beyond the typical neuropsychiatric lupus here, and you are looking at other etiologies, either in the autoimmune, fulminant autoimmune encephalitis category, vasculitis category, or other things like infection. And so you need to cast a wider net for this patient because it is a rapid onset of symptoms that are rare in neuropsychiatric lupus, right? Like seizures and strokes and things like that are more rare than headaches, for example. So we're casting a wider net for a variety of reasons, not the least of which is that she has presented somewhat acutely within 7 days or a couple of days.
Yeah, thank you.
Especially with fever. Sorry to add, especially because she comes with also fever. So I think, now this presentation, labs will reveal some more signs that would actually help us with diagnosis. But otherwise, as soon as a patient comes with this mental status change and fever and immunosuppressive status, you are obliged to treat them with a wide spectrum antibiotic and antiviral and anti-inflammatory until you get all the results back.
Yeah, thank you. Dr. Ansolakis, do you have any specific chronology of the manifestations for autoimmune cerebritis or immune cerebritis compared to non-autoimmune cerebritis, such as start with psychomotor, changing in psychomotor and then neurological manifestation, or vice versa?
So for any type, if you're talking about like an encephalitis or a meningitis in a patient that is infectious, that is not related to autoimmune encephalitis, right? Those patients, even when they're children, will present with the prodrome that you typically associate with viral or bacterial meningitis or encephalitis. They will feel badly in the days leading up. It could be just like this kind of 7-day, I feel kind of bad, I'm feeling worse, now I have nausea, now I have malaise, and then all of a sudden I have a focal neurologic deficit. That could be any person that comes in with an encephalitis or a meningitis that is bacterial in origin, even in the absence of autoimmune disease. For autoimmune driven, at least for vasculitis, that kind of timeline and etiology can be very, very similar. The timeline doesn't really let you differentiate between those two. Now, if you're talking about other neuropsychiatric manifestations of lupus, they happen much more slowly over time. But this 1 week history of symptoms, it doesn't really push you in a direction of whether you're dealing with an autoimmune, like a decompensated kind of autoimmune intracranial pathology or something that is just a run-of-the-mill viral encephalitis.
Yeah, thank you. As you mentioned, around 2/3 part of the neurological manifestation in SLE patient are related to the other etiology except lupus. and just 1/3 of them related to lupus. And I think that neuropsychiatric manifestation due to lupus usually occurred in the first years of disease onset, and the patient usually have active disease, and some manifestations such as the vascular involvement, vascular lesion, and the constitutional manifestations such as fever, cytopenia, all of them can be associated with neuropsychiatric lupus. And if we have a patient with this manifestation, the probability of the neuropsychiatrist may be increased. But in this patient that 3 years ago had a diagnosis of the lupus, and she was under treatment with immunosuppressive, it's better to exclude the other manifestation before they make a diagnosis, not like psychiatric lupus for her.
Totally agree. The other important tidbit here is that most patients with lupus have some sort of neurologic or psychiatric manifestation of the disease. So just the presence of a neuropsychiatric symptom does not like drive you into this category of, oh, do we have to rule all these other things out, right? Up to, there are some case reports, or not case reports, I'm sorry, case series from hospitals that are talking in the 90%, others talk more like 40%. I would say at least half of patients. And so this is unusual because of the time course for which it's presenting, and because of some of the other symptoms that we've already discussed, both vital sign derangements like fever and also focal neurologic deficits and true encephalopathy rather than psychosis. If she showed up and she was floridly bipolar but didn't have any of this other prodrome, you would be thinking that this was just mood related, and you wouldn't be doing an LP, and you may do an MRI, but you're not going to be doing an LP. This is specific to this particular patient, and what you have presented so far about her initial studies.
Thank you very much. Dr. Bijani, can you present?
Yes, sure. But before continuing slides, there was a question which Dr. Afouzian have entered the chat box. Dr. Afouzian, do you want to ask that?
I think my question was answered, so can proceed.
Yes, sure. Thank you. Herein, you can see the initial laboratory data, which was performed for the patient in admission. You can see the decreased level of hemoglobin in the admission of the second and third hospital, a hemoglobin level of 7.9, and then after that 6.8. And at the same time, you can see the decreased counts of platelet with 16,000. And at the same time, creatinine level is normal, and you can see the levels of liver enzymes. Electrolytes were normal with no abnormality. Total protein, albumin, and globulin levels were normal. Amylase and lipase revealed no abnormality. CRP level is normal, and ESR was pointed to be 45. Toxicology screen of the blood and urine was also negative. Her blood group was ORH positive with negative antibody screening. In urine analysis, there were red cloudy urine, a specific gravity of 1020 with a pH of 7, 3+ blood and protein in the UA, and in microscopic examination of the urine, it revealed 20 to 15 RBC and 10 to 20 WBCs in high power filled and hyaline cast and granular cast, a few granular cast, and there were few squamous cells and muci. Due to agitation, CT scan of the head could not be repeated, and the patient was admitted to the pediatric intensive care unit 5 hours after arrival. Let's switch to Dr. Faizi now.
Yeah, thanks you. Now we noticed that the patient had severe anemia, thrombocytopenia, active urinalysis, and high ESR. I have a question from Dr. Khosrow Shahi. Now, what's your diagnosis according to these results?
Yeah, these results are always concerning when you see significant anemia, especially like comparing it to the previous 6 weeks prior to admission, that she didn't have anemia. This is acute anemia and thrombocytopenia in a lupus patient. So definitely you want to make sure that it's not hemolytic and it's not TTP and lupus related. Definitely you still want to make sure you're excluding infections, because in lupus patients a still infection can cause anemia and thrombocytopenia. But now the way that we are looking at her mental status change and fever associated with thrombocytopenia and anemia completely changes. So the next is calling Dr. Gadd to come and take a look at the smear of the blood to make sure there is no schistocyte. And we have to, expedite all the next approaches for this patient right away.
Yeah, thank you, Dr. Khosrowshahi. Dr. Gadd, thank you for joining us and nice to have you. And can you tell us your differential diagnosis according to this result, and what's your next plan for diagnostic plan for this patient?
All right, thank you again for inviting me. Yeah, this is a point where Dr. Khosrowshahi's team and our team usually will meet and start working on patients together. This is not an uncommon scenario at all. Sometimes it is TTP, sometimes it's not. So let's just kind of discuss, what my group or I am thinking at this time when we are called in for such a patient. So whenever there is an acute drop in hemoglobin, there are two big things that we're thinking about. One is a bleed, and the second is hemolysis. Now, these are two main causes of acute drop in hemoglobin. In this patient who came in with stable vitals, the blood pressure was fine, she was slightly tachycardic, but also is in pain. I'm thinking less about bleeding, but still that is at the back of my mind. And in a patient who is complaining of abdominal pain, I would want to also get an imaging of the abdomen, especially if there was, even slight hypertension or tachycardia, which was not in line with her pain or fever. It would make me want to get that also. But that's in the background. Of course, a patient presenting with fever, neurologic symptoms, the drop in hemoglobin and platelet count. The big thing I'm thinking about is microangiopathic hemolytic anemia and thrombocytopenia-like syndrome, TTP, or a TTP-like syndrome. That's a big thing. So my immediate thing would be, even before I see the patient, is to ask for a peripheral smear and look at it. So to continue on those lines, what I'm looking for in the peripheral smear is presence of schistocytes. And schistocytes come in a few different forms. As hematologists and pathologists, we kind of looking for all of those different forms, be it helmet cells or triangular cells, any kind of red cell fragment, really. If I see that, then I'm really thinking about TTP and already taking a step ahead and getting people ready from different specialties like the transfusion medicine folks, primary team to get a central line in, transfusion medicine folks to start making arrangements for plasma exchange as soon as possible, even as I am still working on kind of getting a prelim impression solidified in my mind. I'm kind of mobilizing folks here as quickly as possible. And I would also want a reticulocyte count here. Again, just to, when we think about TTP, it's not a diagnosis that is just pathologic or just clinical, right? We kind of look at a combination of things here, clinical picture as well as some lab studies. So additional labs provide corroboratory evidence, and they help me as I initiate treatment and then follow the patient along. All these additional labs help me sort of solidify the impression and kind of, evaluate patient in a dynamic way as we initiate treatment for a TTP or TTP-like syndrome.
Yeah, thank you, Dr. Gadd. We continue the patient and present some other manifestation and ask again from you, Dr. Bijani.
Thank you. Dr. Fauzi, could I ask you to mute your voice to avoid having echo?
Sorry, Dr. Bijani, I have a question.
Yes, of course.
This is for Dr. Gatt regarding a third reason for platelets to go down like this is endothelial cell injury, which is not hemolysis, which is not hemolytic anemia, but it's just thrombotic microangiopathy without any basically hemolytic issue. Would you agree with that?
Well, that's a great point, and I think there is some need for us to learn, in as a medical community about this particular entity that you speak about. When I mention TTP-like syndrome, that is what I am thinking about. This is a patient who has SLE, and you can have the typical immune-mediated TTP in patients with SLE, or you could have a distinct TTP-like syndrome, which comes with one of the mechanisms of which is endothelial injury. There are other proposed mechanisms as well, but endothelial injury leading to possible aggregation of von Willebrand factor, which then causes consumption of platelets, microthrombi, and a TTP-like syndrome without really there being an Adams 13 deficiency, which we see in immune TTP. So you're right, in a patient with lupus, I am also thinking about TTP-like syndromes, which may be related to lupus. And like I said, there are many different mechanisms that have been proposed, including endothelial cell injury, including just resistance of von Willebrand factor to Adams 13, or a complement-mediated pathway in SLE patients for those manifestations. So yes, I am definitely, that is one of the things also that I'm thinking about.
Thank you, Dr. Gatt.
Thank you.
Let's continue the case. Herein, you can observe the additional laboratory data that Dr. Gatt has spoken of. Bilirubin levels were bilirubin level was increased to 3.5 for total bilirubin and a normal direct bilirubin level. You can see that aspartate aminotransferase was also increased in this patient with an elevated lactate dehydrogenase level. You can also see complement levels of the serum complement levels for the patient, revealing a decreased C4 level and also a markedly decreased haptoglobin level, which is in favor of hemolysis in this patient. Also, D-dimer level is increased in this patient with a normal creatinine and glucose level. And herein is the peripheral blood smear of the patient that we can see the schistocytes in it. And now we're asking Dr. Fawzi to discuss that with other speakers.
Thank you, Dr. Bijani. I have a question from Dr. Leah Pichev. That could you tell us your idea about the PBS findings in this patient and get more information about the TTP in this patient?
Sure. So on this image, we can see a lot of schistocytes, and they were nicely pointed to us by these arrows. Additionally, we can see large platelets, I would say giant forms, and that's immature platelets. That's a kind of a sign that support the low number of platelets on peripheral blood. Additionally, we don't see any other platelets around red blood cells. Additionally, thing that you can notice here that we have relatively wide spaces between red blood cells, and that would support our evaluation for anemia. Another thing that I usually evaluate in patients like that, if we have unusual drop of platelets. And I am usually check if there is any platelet clumps on the side of the smear, because sometimes the machine just can read what we have, and they are not evaluating. They cannot evaluate the clumping. So clumping of platelets, they recognize it as not platelets at all and give us not the real number. So when I confirm that there is no clumping, I'm going and evaluate for schistocytes. So this paper was published in 2010, if I'm correct. And it's mentioned that there is schistocytes were found and it's +1. But what does it really mean, +1? And of course, there was a couple of ways to standardize the hematological evaluation for schistocytes. And the first international one was published in 2012. So 2 years after this paper. The recent one, there was second edition, was published in 2021. It's called International Council for Standardizing in Hematology. And they are, if you want, I can share my screen. Can I share my screen?
Yeah.
Yes.
Okay, let me try. And that, okay, this will stop okay, I will try to do it very fast. This paper. Share. Do you see my screen well? I think so, right? So that's a publication which was published relatively recent, and it's a standardization of how we can count for schistocytes. And it's an international group. Unfortunately, there is no people from United States as far as I see, but it was led by our friends from Italy. They are showing the image over here, and they describing reticulocytes and so on. But we need to remember that reticulocytes, we need to have a different stain. It's Romanovsky stain, or it's a methylene blue stain. And usually what we have H&E. So here we can kind of propose that that looks like reticulocytes, but we cannot see residual RNAs inside the cells. But still, so here we see a lot of schistocytes, and sometimes my clinical colleague or our clinicians asking me, what can you call schistocytes, what you cannot call schistocytes? And this paper is actually addressing these questions as well. That's a nice table here. And you can see what was modified from the 10 years ago and what was confirmed. So basically, the amount of cells which needs to be counted, it's 1,000 red blood cells. And there is two types of magnifications I used. It's a medium, 40x or 400x, or if you're using oil, it's 1000x. I hope everyone can see that. Because sometimes clinicians asking me how many schistocytes can you see? Is it enough to call it positive for schistocytes? And you need to provide some kind of standardization and rely on some kind of research. That's what I'm trying to do all the time. And that's a nice way to, I usually in my report, I even given a reference of this article and sending this, explaining them on what magnification I was using, like what magnification of microscope I was using. And additionally, you can see here that the description of schistocytes, and they kind of help other doctors, if they want to evaluate and confirm your findings, to count themselves. Sometimes it's hard to find a hematopathologist, and it's in the middle of the night, and you would like to review your slide yourself. And that's a nice thing to describe. They are actually nicely describing the schistocytes here. And we need to, of course, remember that if we're finding schistocytes on our peripheral blood, it's not necessarily diagnostic for TTP, or if you don't find any schistocytes on peripheral blood, that it's actually excluding TTP. It's just additional nice piece of information which can help the team to make a decision. So that's a paper which I advise everyone to read. And of course, there is a different threshold. So you can call it that it's increased amount of schistocytes, that there is more than 1% of schistocytes on peripheral blood smear. So that means it's more than 10 cells, schistocytes, 10 schistocytes in your 1,000 red blood cells evaluation. For neonates, it's premature babies, it's supposed to be 5%. So that's the difference too, which is nice to point out. So I think I'm kind of done here. I'm more than welcome to answer any questions and describe this forward. I will stop sharing this.
Thank you, Dr. Leopichev. You mentioned that the absence of the schistocyte cannot exclude the diagnosis of TTP. You mean that we can make a diagnosis of the TTP even before the hematological manifestation, just by clinical manifestation, yeah? And if we can make TTP, diagnosis of TTP earlier, we may have a better outcome as well. You know, when we have a patient with SLE and some manifestation that should be considered about the TTP is the absence of the schistocyte cannot exclude that, even that it make it difficult because TTP and the SLE have share some clinical manifestation that may be related to disease activity or may related to the TTP. And what we will discuss about the difference between the treatment of lupus or TTP related lupus. Thank you, Dr. Leopichev. And I have a question from Dr. Khosrow Shahi that what's your idea about this?
Dr. Faizi, before asking Dr. Khosrow Shahi, I think Dr. Afrouzian has a comment.
Yeah.
Sorry, thank you. I was going to ask Dr. Leopichev if he could kindly show us the helmet cells, the different shapes that and the names that we have for them from your paper, if possible, because you have the arrow with you. You can show us.
Sure. So the hamlet cells, they usually they have a shape which looks like a hamlet right here. But schistocytes is basically
Dr. Leopichev, you're not sharing your screen.
okay, sure. Yes. I was actually looking at your screen. I think you have a nice picture there, and I can describe it from your picture. If you want to go to the paper which I was talking about, I can share it too. Let me share it. Oops.
We can have it. We can see that now.
Yeah. Okay. Great. So on this schistocytes, you can. from the paper we are discussing right now, there is a nice picture as well, and there is a lot of Hamlet cells. But here, basically, what schistocytes are, and it's nicely described in this evaluation. So schistocytes shall be identified based on specific positive morphological criteria. They are always smaller than intact red blood cells. And we can compare it on the slide. Monogeneously stained in most cases. So that was modified from the prior evaluation. So it's stain supposed to be well stained. So it's not just artifact. They can have the shape of fragments with sharp angles, strained borders, and there is Hamlet cell, keratocytes, microspherocytosis. And another thing that I usually looking for in these particular cases, I'm looking for nucleated red blood cells. It tells me that body is trying to recover. That bone marrow is still active, it's trying to compensate for our possible autoimmune process, which is destroying our red blood cells, and trying to push nucleated red blood cells, or immature red blood cells out there. That's reticulocytes, basically, it's immature red blood cells as well, but on H&E, it's kind of hard to see them. We can see the different color of the cells, different size, and speculate that it looks like reticulocyte. But the fragments of nucleus or nucleus itself in red blood cells tell us that body is trying to compensate. So, but here we can evaluate for small fragments, well stained, with pointy fragments of cytoplasm. It looks like somebody chewed and spit it out. That's how I usually explain it to my residents. But that's obviously that it's more than 1% of red blood cells here, right? And I see somebody is wants to ask a question or wants to discuss something. Dr.
Yeah, Dr. Gat.
Yes. Hi, thank you, Dr. Liabyshev. This was very helpful. For my own understanding, because at our institution, hematologists, we review our own smears for the most part and reach out to pathologists as needed. So my understanding is this 1% threshold, and like you said, it's not an absolute criteria to rule out TTP if there isn't as many schistocytes, but what we consider significant is per high power field. If I see 2 or more, that's how I understand it. That corresponds to 1%. If you're counting red cells and then looking at percentage, is that something, or did I misunderstand what you said?
Yes. So basically, if you are reporting about schistocytes, you need to, according to this standardization, you need to tell what microscope did you use, what's magnification did you use. And they allow to use 40x or 100x on oil, so which makes it 1000x. So when you look at the 1000x on the microscope, and you can count, let's say, 20 cells. And out of these 20 cells, you see 2 schistocytes. That's technically can give you this 1% right away. But for us, hematopathologists and pathologists, people who likes numbers and likes to count stuff, we need to prove our point, and we supposed to count 1000 cells. And I actually do agree that most of the institution where I was, our hematology team likes to evaluate the smear themselves, and for multiple reasons, convenience. And I know that trust is good, control is better, right? It's always better to look at under microscope and confirm, okay, I see schistocytes. I am not relying on somebody else's evaluation. There might be resident evaluated and whole pathologists that say, I think schistocytes are there. No, if you're making such a radical decision on treatment on TTP, and I think it's radical, it's deserved to be called in the middle of the night and evaluated, that's needs to be a person with experience needs to look under microscope. They were trying to standardize because some labs previously call +1 schistocytes +1, but what does it mean? Or +2, what does it mean? Previously, one lab can call it +1, and now I'm on +2, and now on it's like, no, there is not enough schistocytes. But what does it mean, not enough schistocytes? That's why I'm trying to educate my hematology colleague here. I'm telling them, okay, I see schistocytes, that's enough to call. And they are asking, what does it mean enough? And I'm sending them this paper. But I'm always welcome to sit down and discuss and show, and I'm giving my my impression. And I always say, tell them that, you know, I am not clinician. I am not responsible for the treatment, but that's what I feel, that's what I see, and that's my evaluation. What do you think? Is there, I'm missing something? Is there any kind of clinical scenario that I'm not, I don't know about it? So that's needs to be decision by a team, and I'm just providing the numbers. That's it.
Thank you, Dr. Leopichev. Thanks for all of your nice information and your nice discussion about this case. Dr. Khosrowshahi, do you have any comment about these findings?
Yes, so I completely agree. And in rheumatology, we are very much used to actually making a decision based on clinical laboratory collaboration of things. So most of our diseases, we don't have one test that comes back positive or negative and you can make a decision. And specifically in lupus patients who develop TTP, which I believe TTP is part of their lupus manifestation. They are not completely separate. Yes, I know that the treatment we will discuss later, and definitely we need hematologists to help us to treat TTP manifestation of the lupus, but it's an immune mediated process that started with the autoantibodies that the lupus process has triggered or is making it worse. So it's the combination of things. You looked at the labs that shows definite hemolysis going on, thrombocytopenia, and mental status changes, fever. So schistocytes is another marker that is going to help you and make sure that your diagnosis is in the right direction. But even if you don't see schistocytes, if it is the earliest stage and for some reason you are not seeing in that peripheral blood smear, again, the conversation with hematologists, making sure that we are all on the same page, but initiate the treatment for immune TTP until we have further workup available.
Yeah. Thank you, Dr. Khosrowshahi. I agree with you that TTP is an autoimmune manifestation of the SLE, and there are evidence that show that the Adams 13 is normal in most of the patients with TTP due to SLE. It means that the pathogenesis of the TTP in SLE is different than primary or idiopathic TTP as well. I have a question from Dr. Gad. Do you need Adams 13 level or activity at this time to confirm the diagnosis of the TTP for this patient or not?
So I need Adams 13 activity sent at this time. I don't need it to start treatment, but I need it for, as I mentioned earlier as well, as we start treatment for this patient, getting that result down the line is going to be helpful. You know, you've all kind of alluded already to the fact that with SLE, we sometimes will see a straightforward immune-mediated TTP where the Adams 13 level is low and the course eventually may follow a similar course to immune-mediated TTPs in patients who do not have SLE. But many a times the course is different, and the Adams 13 level may not be low, and that's because of other mechanisms of microangiopathic hemolysis that can occur in SLE, in which case the course is different and the treatment is slightly different. So to answer your question, I definitely want it sent because it helps me down the line, but I don't need the results right away before initiating treatment for this TTP or TTP-like syndrome in this patient.
Yeah, thank you, Dr. Gatt. Is there any evidence about the other pathogenesis of the TTP and SLE? Which mechanism except Adams and except endothelial damage, endothelial activity can make a TTP in SLE patient?
Right. So, you know, of course, there is still a lot to be learned about this particular phenomenon in lupus patients. But the way I approach this, you know, just simplifying a very complex situation here is a TTP, immune TTP is where Adams 13 level is low, right? And anything else which presents like TTP in my mind, I'm approaching it like as a TTP-like syndrome. And the mechanism is different than reduction in Adams 13 level. And I do also want to mention here before I go into those mechanisms again is, you know, like in any autoimmune condition, there is a tendency to develop other autoimmune conditions alongside as well, right? So similarly, in patients who have lupus, other autoimmune conditions, they have an underlying propensity to develop other autoimmune conditions. And immune TTP, the typical kind where the Adams 13 level is low because of an antibody, autoantibody against Adams 13, can also develop in patients with lupus. So although that's probably a minority as compared to direct SLE-related pathophysiologic mechanisms, such as endothelialitis, such as complement-mediated mechanisms, such as just a resistance of von Willebrand factor to Adams 13 cleavage. You know, so that's the TTP-like syndrome in my mind. That's how I approach it.
Yeah, which factor make Willebrand factor resistant to Adams 13? Is there any change in Willebrand factor or not?
I am not aware of the exact pathophysiology. It may be there is just a change in the way Adams 13 binds to von Willebrand factor, perhaps that, but I am not aware of a definite pathophysiology that is out there explaining this phenomenon. Maybe somebody else knows.
There are some evidence that oxidized von Willebrand factor are resistant to Adams 13, and it's due to the inflammatory climate in the blood of the SLE patient that make von Willebrand factor oxidized, and so they are resistant to Adams 13. That means that we have enough Adams 13 level and activity, but they can affect and cleave the von Willebrand factor and the other pathogenesis that you mentioned. I saw one study that showed that in TTP related to HIV, the level of the D-dimer was higher than the non-HIV TTP. That means D-dimer that is a manifestation of the endothelial damage. And we know that the endothelial damage and activation is common in SLE, especially in active SLE. And so all of these evidence and information show us that the pathogenesis of the disease, TTP related to SLE is different than idiopathic TTP. And when we have a different pathogenesis, is there any different for treatment of this kind of patient or not? What do you suggest as the first line of the therapy for this patient?
Right. And here I would kind of work hand in hand in partnership with rheumatology, Dr. Khosrowshahi and team, because all along, we'll kind of need to revisit this question, how is the SLE activity otherwise in this patient? While we wait for the ADAMS13 activity level to come back, the autoinhibitor level to come back. So regardless of whether it's TTP-like syndrome, I would recommend in this patient who otherwise has no evidence of DIC, and I would start plasma exchange regardless of where this patient actually falls in terms of diagnosis, because plasma exchange will benefit, has mortality benefit in either case. So that would be started regardless. And then overall treatment plan may be slightly different. They tend to behave differently. If there is SLE activity, that's the predominant driver of this presentation, then working with rheumatology to optimize the SLE care is also going to be important. Another thing that regardless works is steroids. So in both the cases, we would start steroids, higher doses in this patient, particularly because she's presenting with neurologic symptoms, which is a sign of more severe disease. Plasma exchange right away. Then other therapies, when we come to thinking about rituximab, for example, decision about rituximab will have to be made one in conjunction with kind of looking at how SLE is behaving, and if we are thinking that just for the control of SLE itself we want to give rituximab. If that's not the case, then I will definitely want to wait for the ADAMS13 level and inhibitor to come back, because if there is inhibitor present, then I will treat this patient with rituximab as well, just like I would do an immune-mediated TP patient.
Thank you. That means you start rituximab in addition with plasma exchange simultaneously, or wait for refractory cases to use rituximab or other immunosuppressive drugs? Right.
So with rituximab, the only thing is, there are two things that will make me start rituximab therapy. To answer your question, no, I don't wait for disease to prove itself refractory to initiate rituximab therapy. There is evidence that rituximab improves the duration of response and also reduces the duration of the acute episode. So it enhances recovery, it hastens the recovery in the acute episode as well. So I don't keep rituximab reserved for refractory cases alone, but I do want to make sure that this patient has immune-mediated TTP before I give rituximab. And rarely there are these cases of hereditary TTP that come to light later on in life. So the thing that I wait for is the inhibitor titer. And the other thing that will make me give rituximab even without that ADAMS13 being low and inhibitor being high is high SLE activity that needs control, where in conjunction with rheumatology, we think rituximab is going to play a role.
Thank you. Dr. Gad, if we need to use plasma exchange and give rituximab to this patient, can rituximab remove by plasma exchange as well? What's your suggestion in this condition?
Sure. If you don't mind, I thought Dr. Khosrowshahi had a comment to make about the previous discussion. So if you're okay with it, I will answer this question after Dr. Khosrowshahi has made her comment.
Yeah, definitely. I was going to say that I agree with you, and majority of the cases of well-known SLE, and like this girl who had activity previously and on immunosuppression, who come with this TTP-like syndromes or manifestations, we definitely start them with high dose steroid. That's the first thing, probably already started before any of these. And then as soon as we see the sign of thrombocytopenia, hemolytic anemia, definitely get the hematology on board and start the plasma exchange as soon as possible. But if the patient has elevated double-stranded DNA or other markers that shows there is a severe flare of the lupus, I mean, at least severe activity of autoimmunity, we also prepare patient to get rituximab. Because of like what we were just talking about, definitely there is data showing that the response to the plasma exchange would be shorter. You don't need to prolong it longer than 5 days. And there is always, you're treating from two sides, reducing the autoantibodies and definitely treating the symptom with the plasma exchange. So my experience has been majority of the TS13 results come later. So we go mostly with the dsDNA titer and, the rest of this lupus activity to make the decision for rituximab. But sometimes if there is no other manifestation, we wait for that, as Dr. Gad mentioned.
Thank you very much. Dr. Gad, what about the prescription of the rituximab in association with plasma exchange or cyclophosphamide or pulse of methylprednisolone? What do you suggest?
Yeah, that's a great question and a very practical concern. So, plasma exchange, as we know, can remove, high molecular weight proteins or protein-bound entities, including drugs, and that's where this concern arises. So, with rituximab particularly, it's known that plasma exchange can remove significant amount of rituximab from the plasma. There is some data that shows, despite that, actually, the action of rituximab on B lymphocytes starts immediately after infusion. So even if there has been plasma exchange after infusion, the biological effect is still significant despite that. Nevertheless, knowing that plasma exchange removes a good amount of the drug, it is better to give rituximab after plasma exchange for that day, so that you're giving, at least 24 to 36 hours maybe before the next plasma exchange comes into play. So that's for rituximab. For cyclophosphamide, prednisone.
Excuse me, when you said that we prescribe rituximab after plasma exchange, if we need more plasma exchange, when we should do it after rituximab?
Right. So
how long? There are different between the some evidence and recommendation about the time between the rituximab and plasma exchange after that.
Right. So we, in this particular disease entity where plasma exchange is life-saving, we don't delay plasma exchange just because we want to give rituximab, which is, the effect on the disease process and removing the antibody is going to take time in general. So the idea is to give rituximab dose after plasma exchange for that day. The patient should continue daily plasma exchanges until they have had platelet count recovery. So for the next day, it's not like, so we don't skip a day just because we have given rituximab. So the patient should get plasma exchange today, for example, get the rituximab, and then get the next plasma exchange the next day, because plasma exchange is life-saving. I mean, there is some, guidance saying if you can, then you delay plasma exchange for 72 hours. However, not in TTP. I mean, 24 to 36 hours, just depending on how the plasma exchange is scheduled the next day. Practically speaking, it doesn't happen the same time of the day every day. So again, to just simplify the answer, no, we don't delay the next day's plasma exchange just because we've given rituximab today. We'll still give it at least 24 hours out.
Okay, we mentioned that the pathogens of the TTP and SL is different than primary. Then we have a normal Adams activity. why the plasma exchange is more important than having a better level of the rituximab to prevent the relapse or prescribing a high dose of steroid. Do you think that the plasma exchange is more important, or they are the same importance, or I have no more experience. I asked Dr. Khosrowshahi as well that which one of these are more important for SLE patient. You know that we will show the response of this patient to plasma exchange. Yeah, as you can see that before rituximab, the patient has a lot of plasma exchange with no good response and it relapse. What do you think?
So I
Yeah.
think, I mean, at least per my understanding as the mechanism of disease of immune TTP in specifically lupus patients, we are approaching both sides. So plasma exchange is treating the current damage or manifestation that is happening due to the what antibodies to ADAMTS13 have done to this patient. So with plasma exchange, you are treating the symptoms that she's experiencing right now. With treatment with rituximab, what is the mechanism of action? You are depleting the B cells, you are removing the B cells that are autoreactive and are making those antibodies that is destroying the ADAMTS13 and causing the vulvar factor problems and all of the microangiopathic problem that the patient is having for future. But as sooner we give this rituximab, so you are stopping the cycle, but at the same time you need the plasma exchange to remove all the damage and everything that is happening. So hand in hand, and that's why like a steroid gets started right away to stop the autoantibodies, but plasma exchange is important. The patients who just receive a steroid, they're gonna just, the outcome is really, really poor. So they need plasma exchange.
Yeah, thank you. Do you have any experience with low dose of rituximab or belimumab for treatment of TTP? No low dose of rituximab.
Not the acuity, I mean, of the time. So we have patients who have had TTP in the past, responded to the plasma exchange, and after that we put them on either low dose rituximab or belimumab just to control their lupus activity. But that is not for treatment of their TTP. It's just to keep their lupus activity down so it doesn't cause any other problems. But for the TTP, that's exactly what Dr. Gad mentioned is really our approach mostly.
Yeah, thank you. Dr. Gad, for replacement in plasma exchange, do you suggest FFE or albumin for treatment of the patient with SLE and TTP?
Yeah.
And
So
why?
FFP is preferred over albumin, and that's because when you infuse FFP, you're also infusing ADAMTS13 along with it. So it really gets to the bottom of the mechanism of TTP, which is loss of ADAMTS13 because of immune-mediated mechanism or hereditary, whatever the case may be. So that's why FFP infusion during the plasma exchange procedure is preferred in TTP patients.
And how long do you prescribe plasma exchange for a patient with TTP?
Right. So
When
our
you stop
groups,
it?
right. So there are two things that you will see. One is to stop abruptly once platelet count has been in the normal range for at least 2 days, and the other parameters are at least improving. Parameters of hemolysis are at least improving. And the other second approach is to taper it out after that endpoint has been attained. For the most part, our group goes with the first practice. There was a time we were still doing the tapering course, but we really didn't see much benefit of that. It just prolongs the stay in the hospital. It also increases the risk of infection because you're leaving now the central catheter for a longer period of time, more risk of clots perhaps because of prolonged hospitalization. So everything that comes with prolonging hospitalization and central catheter stay in the body. So for the most part, our group has moved away from that tapering approach, which in trials did not show any benefit over stopping once the endpoint of normalization of platelet counts for at least 2 days has been achieved.
Yeah, thank you very much. Next, we discuss about the pathologic finding of the kidney. Dr. Bijani, please.
Thank you for the nice discussion. I really enjoyed that. Here is the pathology of the kidney, which was performed, the renal biopsy, which was performed 3 years ago. And you can have the images. We asked Dr. Afrozian to explain a bit more about these images for us and explaining if there would be any chance that endotheliopathy of the patient would be diagnosed 3 years ago or not.
Dr. Afrozian, before you start the discussion about the pathology, you as present this patient. This patient has just lupus nephritis at the beginning of the disease with no other organ involvement, and just with positive anti-double strand DNA made the diagnosis of lupus nephritis for her. And during last 3 years, she has no any other organ involvement. And now we have a manifestation that show the endothelial involvement that present as a TTP with no other organ involvement as well, and just with positive anti-double strand DNA. I have a question that, is there any findings in this pathology that show us that this patient has endothelial abnormality or something that make it suspect to the occurrence of the TTP in future or not? Thank you. And as Dr. Bijani said, is there any finding that show us the pathology is due to lupus nephritis or not? Thank you.
Sure. I would like to share my own presentation if possible, because I have the answer to your question, Dr. Faizi, and there were also other questions regarding TMA and antiphospholipid syndrome in this patient. Thank you very much. I will try to be quick. So this is our
Thank you, it's here.
Just to add one little word, and you can correct me if I'm wrong, administrating rituximab before plasma exchange. I mean, isn't true that with plasma exchange, you're gonna remove all the rituximab that you have already given to the patient? This was my question. Now, just to go to the pathology, I always start with the normal pathology. This is a schematic representation of a lobule of the glomerulus with the mesangium at the center, the capillary loops sitting on that mesangium. And if you follow the basement membrane right here, this area, you will see that on the outer surface of the basement membrane, you have the foot processes of the epithelial cell. And here is your endothelial cell that you are so interested right now to know if this cell has any injury or not. This is a normal glomerulus with patent capillary loops, especially at the periphery. If we had a thrombotic microangiopathy in this patient, I would expect at least some of the glomeruli, not all of them, but some of them to have some thrombi here in these capillary loops. Although it is a focal lesion and difficult to diagnose, but if there was any evidence of thrombotic microangiopathy, you would see them in those capillaries. This is a PAS stain that will show you where exactly the mesangium is and also where the capillary basement membrane itself is. And you can see Now, in this image, really the thickness of a glomerular basement membrane. It's a smooth structure, very thin, and this is a Jones stain, which will also give us a better look of the thickness of the basement membrane. And why am I showing you a Jones stain is because when your patient has proteinuria, it is most of the time the proteinuria is glomerular and it's coming from these basement membrane. So once I hear a patient has proteinuria, my mind goes towards Jones stain and the thickness of the basement membrane. The shape of the basement membrane, as you might appreciate here, this is the norm. Okay. We also use immunofluorescence microscopy, which will give us an idea about the pathogenesis. For example, if this patient has thrombotic microangiopathy, you would expect fibrin to be positive in these peripheral capillary loops. The last thing that we would do is the electron microscopy. This is the normal. We follow the basement membrane and we see what is happening on the other side, on this side of the basement membrane. If there was a thrombotic microangiopathy, this fenestrated endothelium that you are seeing here would detach itself from the basement membrane, and you would see a large space here under the endothelium. In the subendothelial area, you would see a large space. Now, this is the basement membrane that you follow, and this is the mesangium. Okay, now let's go to the pathology. And I know it's dry stuff, and you might tend to have some nap when I'm talking about it, but let's try. So we had 20 glomeruli in this patient, and what was there was a thickened glomerular basement membrane by PAS stain. And how thick was this? Well, I have here my normal on the left, and you can appreciate that these basement membranes are really thicker than what they should be. And there is not much proliferation here. I don't see mesangial proliferation. I don't see a lot of nuclei within the mesangium, more than 4 nuclei in the mesangial area. So this is a membranous that is not proliferating that much. And when I move to the other stain, my Jones stain, that's where I see the abnormality. Again, I refer you to this normal here, and you might appreciate the presence of these structures on the subepithelial, on the epithelial side of the glomerular basement membrane. We call them spikes. They look like spikes. So these are reactions of the basement membrane to the immune complexes that are sitting in the same area. You don't see the immune complexes themselves, but you see the reaction of the glomerular basement membrane. Even in some areas, you can see holes in the mesangium. So there are immune complexes here too. Immune complexes are silver negative, so therefore when they create holes, we know that they are there. Here is a higher magnification to compare the two phenomena. Now, by fluorescence microscopy, we have the position of a lot of things, IgG, A, M, C3, and C1q in a granular pattern along those capillary loops. And because all of our immunoglobulins are positive, we have a full house pattern. And therefore, this is telling us that this might be lupus. Now, to answer one of the questions of Dr. Faizi, The first time they made the diagnosis of membranous glomerulopathy, they did not mention it is lupus nephritis. They just called it membranous glomerulopathy. They did not probably look at the C1q here, which is a good marker for membranous, for lupus membranous. But later on, as you mentioned, the extrarenal manifestations appeared. It is very common for this type of glomerular involvement in lupus patients to act silently. And this type of membranous involvement in lupus patient can even have a serum C3 that is normal, that you would not even, even imagine that this might be a lupus nephritis. So lupus can present with this type, this class of membranous glomerulopathy, and I'm gonna mention a little bit more about it later. But for me, this second biopsy with the full house pattern and the C1q positivity, that is very much in favor of lupus. So here is the electron microscopy. If these areas are our lumen, and these red stuff that I have here is the outline of the basement membrane. You might appreciate that, first of all, the basement membrane is extremely thickened, it's irregular, and it also has some deposits. These are electron-dense deposits that we could see by fluorescence microscopy. And here we also have the spikes, the reaction of the glomerular basement membrane to these deposits. Therefore, we have deposits along the subepithelial aspect of the GBM, and we also have spikes. This is a confirmation of the Jones stain. This patient has this patient has membranous. And on the top of that, in the cytoplasm of the endothelial cell, we have TRIs, or tubular reticular inclusions. Tubular reticular inclusions are signs of excess interferon in circulation. It can be, first we saw them in patients with lupus nephritis, and we call it a marker of lupus nephritis. But then we realized, well, any patient with high interferon would have it, like HIV patient, like patients with COVID-19 nephropathy would have the same thing, even any other viral infection. But when we add all these findings together, along with the TRIs, this is lupus nephritis class 5. Our membranous glomerulopathy differential diagnosis can be primary, but among secondary, the main one is lupus nephritis. And when we add everything now, after the fact that there is also clinical manifestation, extrarenal manifestations of lupus, this is membranous lupus nephritis class 5. So what is class 5? We have an international Society of Nephrology and Renal Pathology Society classification of lupus nephritis. And in this classification, we have 6 classes. These 6 classes show, most of them show a kind of a worsening of the situation from class 2 to 3, from 3 to 4, and so on. However, class 5, which is membranous, is a little bit different. It can occur by itself without any other classes associated with it, or it can be associated or transformed to other classes. And class 5, as I mentioned, is also clinically different sometimes. It can be the very first thing that a lupus patient can present with without any other extrarenal manifestation. And it also basically the treatment for it would be a lot related to the proteinuria that the patient has. Now, by getting up to here, when I go back to my electron microscopy and my other stains, I was not able to show you any microthrombi. I was not able to show you any elevation of the endothelium, any sign of endothelial cell injury that could explain our problems with patients' schistocytes and peripheral smear and basically low platelet. Therefore, I think that at this point, I'm just going to finish my presentation by here showing you the different classes. And there has been also a revision of this classification in 2017. This is the basically the paper that is about it. If anybody is interested, this is a revision of the classification. We are talking about this class here, class 5, where you see the deposits. And I hope that you are not in this situation right now, but if you are, it is still accepted. If there are questions.
Thank you. Thank you very much, Dr. Afrozian, for your lazy cat. Thank you for a really nice discussion about the pathology of the patient. Now we go on the presentation of the patient by Dr. Bijani.
Dr. Faizi, can I just add something?
Yeah.
I think while Dr. Bijani is putting her slides, I just wanted to add a comment. First of all, thank you for reviewing the pathology. Just wanted to mention, I think this pathology was from 2 years ago at the time of the lupus nephritis diagnosis. Would have been very helpful if it was at that time to just look at these, at the time of the TTP diagnosis. But of course, with those platelets and everything else and the situation, no one, I think, would biopsy the patient, and she didn't have any renal manifestation. So this gets back to the question that was posted in the chat in terms of like, would CAPS or antiphospholipid antibody come to the question for differential diagnosis? I mean, we didn't hear in the case any sign or symptoms of thrombosis. So that's the first thing that you should have for if even considering CAPS. Of course, they can have low platelet counts and other endothelial injury, but we didn't have any evidence of thrombosis in this patient. So that kind of like is excluding those. And getting back to the question that of rituximab and plasmapheresis, Dr. Gatt answered exactly what I would have answered. And the rationale behind it is when we treat patients with rituximab, we believe that the first couple of hours, majority of the monoclonal antibody attaches to the CD20 on the B cells. And the dose that we are giving is much higher than the saturation of the oldest CD20s on the peripheral B cells. And the reason is there are penetration of the B cells in the tissue and you're hoping to cover the peripheral and everything. So by the time if like in 24 hours or if you do the rituximab treatment right after your plasma exchange, by the 24 hours, it's time for the next plasma exchange. Majority of their monoclonal antibodies are attached to the B cell receptors, and they have done what they were supposed to do, and you are just removing the exchange extra monoclonal antibody by the exchange. But saying that, definitely some of the monoclonal antibody will be removed, and that's why it is important to repeat the dose later. And because this is a condition that plasma exchange is so important, you don't want to postpone it. But for diseases like GPA or ANCA-associated vasculitis and other conditions that you still combine these two, you kind of postpone your plasma exchange. But this is a scenario that you don't want to be postponing it.
Yeah, thank you, Dr. Khosrowshahi.
Thanks a lot for the explanation of Dr. Afrouzian and Dr. Khosrowshahi. We want to continue the case. As it was discussed, plasma exchange and glucocorticoid administration was done for the patient, and her mental status cleared after the first plasma exchange. Her hematologic parameters normalized after 6 treatment of the plasma exchange, and it was moved to an alternate day regimen. But after one exchange was skipped, the platelet count fell markedly, and the hematocrit level fell, and the LDH level rose, so daily plasma exchange was reinstituted. Results of ADAM TS13 testing showed less than 5% enzyme activity and a high titer of autoantibody inhibitors that confirmed the diagnosis of SLE-related TTP. And although she remained asymptomatic throughout her treatment course, thrombocytopenia and microangiopathic hemolytic anemia recurred whenever plasma exchange was attempted to withdraw. Thus, a course of rituximab together with intermittent plasma exchange resulted in durable clinical remission. And now you can see the graph of the treatment course of the patient with hematocrit, platelet count, and LDH levels of the patient, which is wax and vein, until the rituximab is started for the patient.
Yeah, thank you, Dr. Bijani. Can you show the graph?
Here it is.
Yeah. As you can see, patient, even after 1 month of the plasma exchange, need more plasma exchange as well, and she was refractory to plasma exchange alone. And when rituximab was started for her, the need for a plasma exchange decreased, and just 3 times after the rituximab. And there are some evidence that shows that a combination of the rituximab and plasma exchange and high-dose steroid can improve the prognosis and decrease the mortality from 90% to around 12%. The recent evidence shows that the mortality of the TTP in SL is around 12%. And the survival rate from 40 to 50% increase to around 90% as well. I have a question from Dr. Khosrowshahi. What's your opinion about this graph, and was mentioned you before as well?
I mean, I agree with your stats and everything that you said, that we see rituximab really works well for hematologic manifestation of lupus, and definitely with this patient having such a low ADAM TS13 and most likely inhibitor that is circulating in the blood. So looks like this is the way to go, and that's why we have been mostly doing for our patients.
Yeah. Thank you, Dr. Khosrowshahi. I have another question, 3 more questions. The first is, we noticed that most of the manifestation of this patient 2 days before admission were attributed to the tapering of steroid and to the stress of the school by primary care physician. What do you think? Do you think that our primary care physician should get more information about the follow-up the patient with SLE and pay more attention to each manifestation when they have a SLE patient?
And lupus patients are really challenged to treat and manage, and I think many of our patients could have similar symptoms with fatigue and generalized symptoms that is really related to the stress and taper of the steroid, and not that everyone would have the worsening of their lupus symptoms. But yeah, that's what these kind of cases are the ones that bring up to the attention of the doctors, that if there is a serious lupus diagnosis, so we have to take it more seriously. But sometimes it's the earliest stage. Sometimes you are just going to have that generalized fatigue and nothing more than that, and blood work in it is not going to show you. But it's important that they get a follow-up with their rheumatologist, they get a follow-up with blood work and urine test, and definitely evaluating the whole panel of their lupus activity is prudent. So what I would suggest is primary care doctors, if they can't find on their exam any manifested, majority of lupus patients may have a rash or arthritis, something that would trigger. But if it is just generalized, sending them to rheumatologist would be the best. I'm sure Dr. Gad knows our system, and it's not easy to get them to see their rheumatologist right away, but at least sending a message and making sure that they would have a blood and urine test that would at least show some evidence and close follow-up is the best way to go.
Thank you, Dr. Khosrowshahi. And we noticed that despite the positive anti-double strand DNA 6 weeks before admission, the patient has a tapering of the corticosteroid as well. Do you agree with this plan or not?
I mean, that's a controversial also question, and we believe that we don't treat autoantibodies. We do have some patients that are, we call them clinically quiescent and serologically active, and their dsDNA may never be normalized, or their complements may never be normalized. So and we all know about the side effects of the steroid. So if clinically patient is doing well, I agree to taper the steroid and get them off the steroid. And actually this paper was 2010, and now in 2023 we definitely have shorter courses of steroid treatment and making sure that our steroid sparing agents are maximized. But you know, I look at dsDNA titer as just for a marker for myself to how to follow up patient closer and just take their symptoms more seriously rather than increasing the steroid.
Yeah, thank you. Thank you very much. You mentioned very important issue that when we have a patient with positive anti-double strand DNA and we have no other manifestation and we decide to decrease the dose of the steroid, it's better to have a close follow-up for this patient and ask him to come back if she or he has any manifestation that may be related to a flare of the SLE. Yeah, thank you very much. And the last question is, we don't found any hydroxychloroquine in treatment of the patient with lupus nephritis. And what do you think? Is it necessary to use hydroxychloroquine as a baseline of therapy for any SLE patient, even when we have just lupus nephritis for the patient, to prevent the relapse and to have a better prognosis for even lupus nephritis?
Definitely, I completely agree with you. Any diagnosis of lupus, cutaneous, systemic lupus nephritis, we put them on hydroxychloroquine because if the studies have shown their outcome of patients is much better. They have less flare-ups. So that's definite. And I mean, I deal with patients, pediatric patients who transfer to adult clinic, and they have the challenge for 16-year-old and 2 years or 3 years prior to coming, which would be 13, is not easy to take too many medications. So I can understand that, but definitely a standard of care is to put them on hydroxychloroquine.
Yeah, thank you very much. And if there is no any question, I hope that this information from this discussion help us to prepare to have a proper approach for our patient with TTP due to SLE in future, and hope to see you again in the next rheumatology CPC in next 1 month. Any question and any comment from the invited speaker?
Dr. Faizi, let me say the follow-up of the patient very briefly. 1 year after this episode, the patient is doing well. Her kidney disease is in remission. The TTP has not recurred. Her platelet count, hematocrit, and LDH level are normal. Her proteinuria is slightly better than before, and she continues to take mycophenolate mofetil and 10 milligrams of prednisone per day. And here you can see the entrance of Medical School of Tehran University of Medical Science that may be nostalgic to some of our speakers. And thanks for joining us. We were so much grateful to have you with us. And we hope that everybody had enjoyed the discussion. And if there is any questions, we appreciate to have them. And have a nice day. I think Eleni wants to express a comment. We have you, Eleni.
Thanks. I just wanted to say thank you so much. I really enjoyed the discussion of TTP in this particular case. It's very, very interesting. I will just point out very quickly, I know we moved away from neurology very quickly in this, but patients with TTP are more likely to have mood disorders and memory and cognition impairments after TTP as a symptom that remains. And in patients with lupus who may have an increased risk for those to begin with, it's always important to do your depression and your mental health screening in these patients to make sure that you're not missing depression that could otherwise be very easily treated in these patients. That was all I wanted to say. Thank you very much. I really appreciated it. Thank you for the invite. I loved it.
Thank you very much.
Can I also make a comment just to complete the discussion that I started? I'm assuming a B12 level was already checked when a patient presents with neurologic symptoms and cytopenias. We see that also. Just to wrap it up. Sorry. Thank you.
Thank you. That's really correct.
Thank you all. I have shared the link of some papers. I think I have echo. Yeah. Okay, I have shared the link of some papers, the ones that have been discussed here by our speakers, and some more. And also, I have shared the link of the evaluation form of the sessions, and it would be really great if you could help us with filling out those forms as well. Thank you very much.
Dr. Baharwan, I have a question regarding the previous and this session.
Yes.
As you said, there you are providing us with some, what did you say? For our activities, are you providing?
I did not get your question very well.
Okay, I will.
Points, like CME points or something like that.
CME points, yes.
CME points. Okay,
Yes.
For our participants in Iran, yes, we have some CME points. But for our speakers, no, actually for our speakers, we have a certificate from Tehran University, and we will email them to you.
Okay, thank you.
Thank you very much.
Thank you very much.
Much for invitation. I really enjoyed. I learned some interesting stuff, and I'm glad that we are internationally on the same boat of fighting this disease. And thank you very much, and have a wonderful day.
Thank you.
Thank you.
Thank you for presence.
Bye.
Thank you, everyone.
Have a good day,
Bye.
everybody.
Bye.
Bye.